was it the same body of people that were like, yeah, we'll put you through nursing school, like we'll graduate you. Oh, but we're not gonna like utilize you in the workforce.
Oh, of
Like
course.
that's
It's
insane to
crazy to
me.
think about. It is crazy to think about. But you know, what we don't understand is just it's again this facade that healthcare has to be perfect. And there is no such thing as perfect because if you're
Hmm.
perfect then you're weird. Like every single one of us is different and we all do things differently, and because we don't see someone being able to do something, we don't automatically give them the opportunity to do it.
Hey, what's up, everybody? This is Maggie Reichard, pronouns she, her. I'm a medical ICU nurse and your host for Nursing Uncharted, the podcast that uncovers all the ways that we use this license, all the while having uncharted conversations about the profession in the process. So thank you so much for checking us out today. If you're looking for more content after the episode, you can check out our Instagram page at Nursing Uncharted, no spaces. And we are also on YouTube if you'd rather watch our episode today. And we do clips of highlights of the episodes on there as well. So today, we have a great episode about being your own health advocate. Because as nurses, we dedicate our lives to improving the health of others, but we don't often have the same respect and motivation to be advocates for our own health. And a lot of people feel like they can't work bedside if they are, or if they become disabled, because hospitals don't generally accommodate those disabilities for their workers. And one nurse in particular put her finger on that pulse and made it her life's work to help others pursue their dreams, whether they be disabled or able-bodied. So her name is Andrea Dalzell. She's also known as the Seated Nurse. Andrea is a registered nurse, a healthcare advocate, disability rights influencer, speaker, and most importantly, a survivor. At the age of 5, Andrea was diagnosed with transverse myelitis, an inflammation of the spinal cord that causes pain, muscle weakness, and paralysis, and she was using a wheelchair full-time by 12 years old. Inspired by her experiences with nurses, she received her nursing degree from the City University of New York, College of Staten Island. Andrea became the first registered nurse in a wheelchair in the state of New York, and she devotes her career to helping others with disabilities live healthier lives, whether seated or able-bodied. Andrea was crowned Miss Wheelchair New York 2015 and utilized her title and platform, Life, Liberty, and the Pursuit of Access, to promote her message and belief that people with disabilities can live a fulfilling life. As an advocate and activist, she has won national recognition over the years, including being named New Mobility's Person of the Year in 2021 and the inaugural Craig H. Nielsen Visionary Prize winner 2020. She's also been featured in Unite Spinal, Home Care Magazine, Apple's iWatch campaign, YouTube, and Forbes. So, Andrea, I am so honored to have you on the podcast today. Welcome to the show.
Thank you for having me. I'm so excited to be a part of this.
This is awesome. I first heard you speak at NurseCon this past April. And you talked about your journey of, as a nurse with a disability and, the lengths that you had to go to become a nurse. And you had to show so many people across the healthcare spectrum, that you could work bedside, and you broke that glass ceiling for persons with disabilities. So
I hope so.
So I'd love to start the podcast out today, just like telling that story over again, telling our listeners, how you became a nurse and what that looked like.
Yeah, for sure. I think okay, let's rewind a little bit because, a lot of us in nursing always had this passion to be a nurse, right? We grew up, or either our parents, someone in our family was a nurse, and therefore we kind of like picked up the torch and ran with it. Well, there's no one in my family other than me that happens to be in nursing right now. There was no one that was a nurse when I was younger. So the nurses around me were those that were the influence. And honestly, I thought I was going to be a doctor. I thought that all these doctors, let's rewind a little bit more. At first, I thought I was going to be a lawyer, right? I have this diagnosis. I'm going through all of these ins and outs of the hospital system, pokes and prodded by doctors, and I'm telling them I'm going to come back and sue them. That's why I was going to be a lawyer, right? I'm coming back to sue you for all the pain that you have put me through.
Yes.
Well, the funny story there is when I went to a graduation, my doctor and his NP came with me, and they wrote in my memory book that day, "Please, anything but a lawyer." Well, okay, fine. If you really believe that I might have had the power to come back and sue you, then okay, I understand why you write this in my book. And now I'm going to go to college and I'm going to study medicine, because if you can't beat them, you're going to join them. And I wanted to figure out a cure, some way to possibly walk again or not have pain. And you know what? That's also a pipe dream, because, you know, there's always going to be pain in life and there's always going to be some type of disability in life. And I also realized that in auditing medical school classes, that everyone is really their diagnosis. They're no longer the human being. They're no longer Andrea. They're no longer Maggie. They're no longer who you are. And therefore, I can't just see you as a diagnosis. I can't just see you as, you know, all of the comorbidities that we go through, because that's kind of what healthcare is. That's what insurance encourages.
Yeah.
So I can't do that. Now, the nurses around me were like, well, why not be a nurse? Right. I should be a nurse.
Yeah.
Here's where the other problem is. I didn't think I could be a nurse because there's no representation of nurses with disabilities.
Yeah.
Healthcare has this perception that we have to be perfectly healthy in order to care for people. And they keep that facade really nice. Whereas, you know, all of the teams that I've ever had, all the healthcare teams I've ever had, I've never seen someone with a disability. So subconsciously, someone's telling me I could be a nurse, and subconsciously I'm like, no, there's no way that's going to happen. Like, I don't know how that would even start that process.
Yeah.
I started the process. I finished the process, not like without undue hardships, right? Because there's unknowns there and subconscious biases about disability as it is. But I did it. I got through nursing school. I was the first for New York State and the first for my college. And let's turn that into a career. And that's where I really hit the blockade. The blockade of, okay, we were able to educate you, but do we really believe that you could do this in the real world? We can put you behind a desk. We know you could do desk work, but can you really be hands-on with patients? And
that's amazing that they didn't, like, it was it the same body of people that was like, yeah, we'll put you through nursing school. Like, we'll graduate you. Oh, but we're not going to like utilize you in the workforce.
Oh, of
like,
course.
That's insane
it's
to me.
crazy to think about. It is crazy to think about. But you know, what we don't understand is just, it's, again, this facade that healthcare has to be perfect. And there is no such thing as perfect, because if you're perfect, then you're weird. Like, every single one of us is different, and we all do things differently. And because we don't see someone being able to do something, we don't automatically give them the opportunity to do it.
Yeah.
And I don't fault anyone for that, you know, and I maybe we should really like stick on that narrative for a second. It's like, I don't fault anyone for seeing me as unable or not being able to achieve something that maybe they would be able to do because I'm sitting down versus them being able to stand. But then I asked the question, I sit at about 5'1", and I went through nursing school, which case I had to prove to not only my education, but to the nurse managers on the clinical floors that I was at that I can do the job. And here I am, and I've passed my NCLEX, and now I'm in the workforce, and I'm trying to get this job. And I'm like, well, doesn't all of the training that I did in school prepare me for this point? And everyone was like, no, it doesn't. And I'm like, but it does.
But it does.
But it does. Like, you're hiring my friends, you're hiring my cohort. So I know now that it's not just what you think, right? Because we've already been given this training. So now, you know, it's this perception that it can't be done. And that's just because you haven't seen it. Again, the same representation that I was looking for to believe that I can do it in the first place doesn't allow for someone else to also say, well, yeah, they can do it. Why can't they do it? They may need a little help, but what does that help look like at the end of the day versus that person being a burden?
Yeah. Right.
And because we're in healthcare, and because we usually see people at their most vulnerable state, and when we're talking from the bedside point of view, people are at their most vulnerable. They're at their weakest. So now we kind of transition that back into someone else who's now working full time in a wheelchair and saying, well, they're the same person as that person that I take care of in the bed. No, it's two different people now.
Yeah. I mean, and you would think, like, I mean, we are hospitals, like we have the means to accommodate, you know, disabilities, but it's just a paradigm shift, I think. Like it's a cultural thing, it's a mentality thing that like we can't provide those same accommodations for our own staff.
Well, look how much that has changed also, like given the fact that we're in this endemic that is perpetuously like crippling our systems, and how much of the work that I'm doing right now actually helps more of my counterparts who are standing up than it actually does for anyone else. Because I'm talking about the fact that your rooms are fire hazards with all the stuff that they clamor into them, right? Your own ability to be able to get in and out of the room safely, your own ability to ambulate a patient, your own ability to perform your job at its quality, at its best, is hindered because of what the institutions want of us versus what we can do for ourselves, right? They want you to be able to just pack everything into a room and then maybe put it outside in the hallway, and then it's a fire hazard, so put it back in the room, and then in the room it's a trip hazard or a fall hazard for the patient, and all of these different moving parts that no one's really taking a moment to say, wait a minute, this is all accessibility issues.
Yeah.
This is everything that we already talk about and do. So when I'm coming in and I'm rolling into the room and they're thinking, well, she can't do it, how's she going to reach the back of the bed? Well, let's move the trash can and the chairs and everything else out and only keep what we need in there for the patient's safety. And then maybe you will be able to reach the back of the bed and I'll be able to reach the back of the bed. That's the purpose.
Yeah, absolutely. I mean, what other, so like, yeah, what things did you find? I mean, you know, when you were in that job, what kind of...
Oh man, there's so many different, well, okay, let's talk about the common biases that get thrown my way, right? Automatically, the top three things that I can think of is, one, how am I going to be able to do CPR? They instantly think that I'm sitting down, that CPR can't be done. Well, how does a 5'1" or a 4'5" nurse do CPR? They get on a step stool, right? And they get to work. Right? Well, the beds go low enough, I sit high enough, and I took up boxing to be able to keep up stamina, to be able to do chest compressions from the seated position. Right?
Anybody should be taking boxing. That is hard stuff to do. Every time we do CPR, I'm like, I need to work out for this job.
But it is a workout. But how many nurses do we know who do not have any type of visual or mobility issue that can't do CPR? That can't get through one round of it. You know, there's this unconscious bias that healthcare workers have to be healthy, or that disability equals inability. Those two things are not synonymous, and therefore, when we are considering the safety of our patients or the health of our patients, we should actually be pressuring the institution to keep up with technology.
Yeah.
So that we're not hurting ourselves, breaking our backs, throwing our backs out, hurting our knees, whatever the case is, because they had the devices that could do CPR for us. Right? Right?
So true. That's so true.
But all of these institutions just made a whole lot of money off of us last year. So they're not worried about your back going out. They're not worried about your knees or your feet hurting or anything else. But here we are changing that narrative to put it back on the person with the disability as a blame. Like, how are they going to be able to do this? Yeah. So CPR is one of them. Ambulating a patient. Well, if we didn't have short staff, our nurse to patient ratios weren't out of control, and that we actually had the devices that we need, ambulating a patient would be as easy as just getting them ambulating belt and holding them up, or getting someone else to help you. Right? Again, the conversation throws back to the person with the disability, like, how are you going to be able to do this, versus what is the institution doing to make sure that everyone, whether you have a disability or not, has what you need to be able to do the job.
We'll be right back to our interview. Grab a cup of coffee, but don't go anywhere, because we want to talk to you about our podcast partner, American Mobile. No matter your specialty, American Mobile has endless travel nursing opportunities. With the largest clinical team of all staffing agencies, American Mobile is ready to support you in achieving your career goals. To learn more about the benefits of American Mobile, like higher earning potential, premium health coverage, and 401k matching, make sure to visit AmericanMobile.com to speak with a recruiter. Again, visit AmericanMobile.com to discover your next travel nursing adventure. Now, back to the show.
Lift equipment is so, why doesn't every place have adequate lift equipment. Like it makes so much sense in order for us to like not, break our backs, like you say.
Right. But we're also the profession that has the most injuries.
Mm-hmm.
Out of all the professions that you could possibly think of, and that may blow your mind, but go and look up the research, guys. I'm telling you, I'm talking facts right now. We have the most injuries because we're physically lifting patients 12 hours a day throughout our shifts, like no matter which way we do it.
Mm-hmm.
So ambulating, we have CPR, and then like the other one would be something like, how am I going to be able to hang on an IV pole? Well, I know a lot of the short nurses tip their IV poles, so it's no different for me. I'm going to tip my IV pole and hang it up. Like, there's all these tricks to the trade, but asking someone with a disability to have to explain how they're going to do something to you when you don't do that for everyone is another, like, again, let's check that subconscious bias and be like, you know what? Yeah, however you're going to do it, if you need help, just let me know.
Yeah. Nobody should be setting your own limitations, based on what they assume your abilities or disabilities to be.
Right. But then that help can come back to you in another way, right? Like you may be swamped right now, and I'm the best at IVs, and I may be swamped, but you know that I can get those IVs in 2 seconds, so you'll call me to do it while I'm, not worried about me trying to reach the IV pole. I'm going to ask you to maybe hang that line for me, and I'll hook it up when I come back from doing your IV, right? Like,
yeah.
We are so focused about, we hear these terms of like, eat our young, right? That's a quote unquote for nurses, veteran nurses to younger nurses, or younger nurses bullying older nurses, and how within our own profession we're at each other's throats sometimes. But the thing is, from nursing school, we should be really enforcing that this is team effort. You cannot do this job alone.
Yeah.
Even if you thought that you could, you cannot. Whether in the percentage of women that are in this profession as well should also know that when we have a moment in time where we're going through something during that month, whether it's 9 months of something that you're going through, however it is that you present to your job, we all have to be helped at some point or another. And I think we focus too much on the fact that someone becomes a burden versus, no, we need to help them.
Yeah.
And in order for them to perform at their best.
Yeah.
And then some people will say, well, others are taking advantage. Well, then call those people out.
Yeah.
Call those people out on it. That's it.
The lack of awareness with people with disabilities, I mean, I think it goes both ways. It's like, we won't let them in the door. And then when the current nurse workforce becomes disabled, they won't let them leave. Or like the disability that they have isn't, you have to break your back or herniate a disc or, in order to actually get accommodated for things.
Imagine that.
It's wild. It's wild. It's wild. I feel like I'm in my 3rd trimester of pregnancy right now, and I want to like frame this perspective delicately because I'm not ignorant to my own able-bodiedness, but I think like being, I became not able to do the job that was within normal expectations, I think, just in the last few weeks. Like I pulled a muscle in my neck, my feet were completely swollen, so I couldn't wear my normal shoes, and I got plantar fasciitis, and I got carpal tunnel, and like I was falling apart, and I was like trying to do the same, job, and they were all pregnancy related injuries. But like, I felt like I was only worsening my physical health doing this job in a time where everybody's like, nurture your body. I'm like, that's hilarious. I'm not able to do that.
There's no way to do that right now.
There's no way to do that in the confines of what I was trying to, like, I don't like asking for help or, and a lot of times like we're short staffed, there's not a lot of help around. I mean, like if I have to take a patient with CRRT and like hang those like, 10-pound CRRT bags, like that's on me to do. And I feel, and for the first time, I feel like I was made aware of some of the pitfalls in the hospital when it comes to accommodations.
Oh yeah.
because like nobody I knew at my current job ever like asked for, you know, any accommodations or like any kind of like light duty. We just don't know that that's, you know, available to us. And I think culturally, we just don't even consider that as an option.
Well, I mean, of course not, because what are you asking for at the end of the day? What are we going to HR and literally say, hey, I need an extra hand so that I'm not lifting 20 pounds on top of the extra 10 pounds that you're carrying in blood weight, in fluid weight, in baby weight. Like,
yeah.
Like what else, right? And we don't think about it. So I also think about it in terms of my nurses who are working with type 1 diabetes, who need to take a moment to do insulin calculations so that they're not running on low glucose throughout their shift and getting a minute to actually take a break to eat and let that actually absorb to their body so that they can work at their greatest potential. How are they going to HR saying, I may need to take a 10 to 15 minute break every 4 to 8 hours because I need to check my glucose, or I may need to take a 10-minute break every 3 hours just because I need to eat something and ensure that I eat something. Right? Like, that's not even an accommodation to be like, oh yeah, just take your break. But in nursing, you can't just take your break. You can't just get lunch. You can't just take 20 minutes to put your feet up so that you're not swelling on top of the compression socks that you have on, right? Like, these are all things that we don't think about. Like, how do we even approach these accommodations? And then we go to our nurse managers and they get mad when you can't do something.
Yeah.
And I've been a nurse manager, so I know what it's like when one of my nurses comes to me and has some physical issue, and I'm thinking to myself, okay, well, I can't keep them on the floor, but I also don't have the staff. And I'm about to head into a meeting, but then I'm going to be short on the floor if I'm not there. And so, yeah, it's not a nursing problem. It's an institution problem.
Yeah.
It's an institution problem because there's an EEOC statement that every institution abides by. And it says that we are an equal opportunity employer that allows for women, men, any gender, military status, whatever it is that you are, purple, green, orange, you are allowed to work with us. And we support that. Well, how are you supporting that? What are you putting into place to ensure that those that are coming to work for you are taken care of, and those who you may like that opportunity of female, male, like, how are you ensuring that they're welcome to come into your space to work?
Yeah.
Now, if you think about women coming, like those that identify as a woman and female, and they're coming into your space to work, are you setting up a place for them to be able to be comfortable in that space? Like, do you have gender neutral bathrooms? Do you have spaces for when your employees may have a child and are gone? Are you just going to grab temp agents, or are you going to make sure that there's enough nursing staff that you can have that nurse covered, or add an additional person because that nurse now becomes a half nurse because she may need extra help? It's whatever the institution is actually in placing. So I try to tell nurses now, it's far more than your contract to just look and say, well, I'm making this amount of money and I have this much PTO. Now, when you're going into those interviews, you should be saying, well, how do you best help those that are coming into work for you? How do you address disability? What if today, tomorrow, I broke an arm? What does that look like? And they will tell you, you have to wait a year for your disability to kick in, or you have to be with us for this amount of time. Well, then that doesn't care for you either. It's time to start pressuring these institutions that literally make money off of us being in the building and saying, you need to provide for us. You need to ensure that if we're working for you and we're under these conditions, that if something should go wrong, that you will provide.
Yeah. Yeah. Absolutely. I know. What do you think stood in the way the most when it comes to not accommodating disabilities? Like, do you think it's the culture? Is it the plain lack of policy? I mean, like, you know, we talked about the EEOC, but like, is it maybe a lack of awareness of that policy? Like, where do you think, you know, what stands, or is it just a combination of all of them?
I think it's a combination of all of it. I don't think that anyone who becomes a nurse manager necessarily understands how to check biases during an interview. A lot of nurse managers that you will sit down in front of are the ones that are the final decision makers for when you are being hired to their unit. And when you're sitting down with HR, it's a different discussion than what you're sitting down with nurse managers. That's one. And then, you know, if nurse managers think that there's any type of accommodation, they don't think about the safety aspect. They're automatically, well, it's not safe. We're an evidence-based practice. Show me where infection control is an issue. Show me where mobility is an issue. Show me where anything and everything that you could possibly think of. Show me where it's an issue in evidence-based research. Show me the research. I'm that person. Show me the research. No one can ever show us the research. So when you're sitting with HR, they know to abide by the ADA. But when you're sitting with the nurse manager, they're not exactly trained on how to check their implicit biases while they're hiring someone. So therefore, that person never actually may feel like they've gotten their whole person seen. If they have a disability, if they have an invisible disability, right? There's no way to really figure it out. There's no web there to say, well, yes, if I have an invisible disability or a physical disability, I can click this button and it's going to tell me what the next steps are. It doesn't.
Yeah.
And HR is really about the institution, right? So they're going to try to hold on to every last dollar. So they're not really trying to give you that information either. They're not trying to willingly say, here are the steps to get what you need to make sure that you're good.
Yeah.
So it really takes the culture to shift, to say, no, this is what we need to discuss. This is how we're going to best ensure not only retention, but we're going to ensure like a good working environment because people feel cared for, feel welcomed, and feel heard. Like their voices can say, hey, this is what I need, and those needs be met.
Yeah. You talked about retention, and it's so true because, I mean, a lot of people, like I don't have a lot of people at my current place where I work, they leave the bedside or they, you know, they go to like a procedural area or outpatient positions, like in order to get that accommodation of light duty. And it's like, you know, if we were just aware of the kind of accommodations that we could, you know, be provided, it would keep people at the bedside.
Of course. Well, HR would also have to say, well, up to E-Team, their executive leadership, like these are the amount of requests or these are the things that are coming in that we should probably figure out a way to provide for. It's not once or twice that a nurse is going to come and say, I have type 1 diabetes or I have high blood pressure and I have massive migraines that come on out of nowhere that I may need to take 30 minutes to sit out and take a medication for it to kick in for me to come back to the floor. Like if HR is seeing, or if someone even felt seen enough to be able to go to HR and say, this is what I'm looking for and this is what I need. And then HR takes a track of things that they're possibly getting requests for or having conversations about, just whatever topic, whether it's pregnancy, type 1, high blood pressure, mobility, whatever it is that they're seeing. And then going back to executive leadership and saying, hey, how can we then implement ways to help these employees or ensure that, you know, employees don't even have to come and ask us, like they know that this is available.
Yeah.
It automatically changes the way someone would work.
I think that just made me think about the nurses that are currently in the workforce probably don't even know. They don't even think about the things that they're going through or something that they could be accommodated for. Like migraine. I didn't even, you know, that hadn't even occurred to me, you know, and like type 1 diabetes, that's so important. Like, can we like run through some of those things for, you know, nurses that are listening? We're like, oh, I didn't even realize, like maybe I should be asking to, you know, see if this can be accommodated in some way.
Anything and everything can be accommodated so long as there's a need, right?
Yeah.
You have a medical condition. Guess what? We work in healthcare. We should be able to accommodate this. We already accommodated for our own patients that we're seeing right in front of us. So now we just need to shift that. If we're telling our patients that they need to drink water, or type 1 diabetics, that they need to drink water and have a meal every 4 hours and they need to check their blood glucose, guess what? That's your accommodation. Not us, right? But that's your accommodation too. Because let's be real about one thing. Nurses and doctors are the worst patients. We do not take care of ourselves. We wait until the last minute. And the last minute is often enough the ones that are ending us up in our own EDs and our own facilities. So No, we need to not get to that point.
Yes.
But we also need to be wary of those that are on our floor. Like 9 times out of 10, we're going to know that our colleague is dealing with something, or there's going to be one of us that knows that they're dealing with something physically or mentally or health wise that they have to take care of. And one of us will be like, yeah, I got you. No worries. Get off the floor and I'll take care of you. I'll take it. Right. But what if that was just a part of the narrative? What if HR said, hey, if you said to us that you have any type of medical issue that needs to be taken care of, whatever, you have your doctor's note, here's your accommodation, we have the staffing for it already. Again, that plays into retention, that plays into someone feeling like they're cared for and heard for in that position. So yes, you can take a minute, you can ask for an accommodation every 4 hours where you need to take 30-minute break, right? You can always ask for, you can have 3 consecutive shifts in a row because you need to do whatever else those 4 days, because those 4 days could be related to health related issues, mental health related issues, family related issues. That's an accommodation where you can have your schedule set for 3 days no matter what you do. People will be like, oh, what? I've never knew that. Yes, you can have your schedule set. You can have it where your accommodation is shifting you to day shift for 6 weeks because of whatever reason that you need to. And HR can abide by it. That's what we call them, reasonable accommodations, right? Institutions will say that it's not reasonable because we'll be even more short staff on whatever shift you're on. No, that's your job to provide. That is a reasonable request I am asking for. It's your job to comply. The thing is, we also get afraid of filing reports. We get afraid of putting in those critical incident reports. If you're short staffed, put in the critical incident report. Start telling on your institutions, because that's when change really occurs. I can walk you through every single thing that you can request for an accommodation, but honestly, those accommodations are going to come regardless once you start putting in reports when things are bad. Okay? When you have those fire hazards, when you have those trip hazards, don't just fix it. Write the report. Write the report. Put it in. And then when you get, if you need to have a reasonable accommodation, let's say you need to get off your feet at 6 months, you are carrying with child, and you need to get off your feet at 6 months, but you know your maternity leave will not cover you. Get your accommodations. Okay, you need to sit down every 30 minutes. Who's going to tell you differently? Oh, the hospital, because they don't have the staff to help. Again, that's not your, oh, my light just went off, guys. I'm so sorry.
It's okay.
But it's also not, it's not their fault, right? It's not the person's fault. We're not adding the blame back to that person. We're making sure that the person knows that they can come and ask for those accommodations and they'll be provided for.
Yeah.
Because those CIR reports are going to make sure that they're always going to be followed up on. We don't want the bad reports. We want the good things.
Yeah, right.
We want the good things. And the good things is always going to be from what you've requested and what we've been able to put through.
Yeah. I think, and a lot of it too is just knowing what your policies are in your hospital, like being aware of what is, like, that's what I found a policy at my job that was for pregnancy. And it was, they had said, we don't discriminate against pregnancy related injuries, and you can be accommodated for longer breaks, more bathroom breaks, change in job responsibilities, even a temporary job transfer, and so I was also like in conversations with employee, HR and my manager, but I think like, it took those 3 things to be like, oh, okay, like, yes, this is a reasonable accommodation that we can provide. We will put you on light duty. And that made all the difference. Like, my muscle pain is not there anymore. Like, and I didn't have to leave the bedside. Like, I'm still like working, acting as a resource on the unit. I'm doing things within my means. And then I am going to come back to the workforce, when my baby is born. Like, I didn't have to like completely change, my whole job.
Sure. Well, that's also the same, right? Okay, so I know we've touched on all of the things that we normally see, right? So the top 3 for me in healthcare, especially with my team, it's usually, childbearing, type 1 or like migraine, like massive migraines, or even high blood pressure. But let's think about a perfectly healthy nurse, quote unquote, for the most part, who comes to work, leaves one afternoon, and has some type of an injury, and then doesn't know how they're coming back to the bedside. Right?
Mm-hmm.
Most times people are going to be like, no, you can't come back to the bedside. We don't even believe that we can go back to the bedside if we've been injured. So then the runaround becomes, well, can I return with a mobility device? No. Can you return with a cane? No.
Yeah.
Can I return with a cast? No. And the thing is, yes, you can. You just need to figure out what those accommodations look like. And I'll be completely honest. A lot of people who are newly injured or have a new diagnosis, you need a transition period. You need to understand how this is going to affect your life first. A lot of us as nurses, when something bad happens, guess what we do? We run right back to the bedside, right back to hands-on, and we dive deep into our job. We don't want to think about whatever it is that's going on, and we try to put it off as much as possible. And I think a lot of people do that in any other venture or profession, but particularly nurses. And why is because we always care so much. Our team is not going to be working at their capacity without us. We have to be there to help them, right? Yeah. Our patients need us. We need to be there for them. And I think that we kind of forget that we're humans and we kind of have to take care of us first and be at 100% before that we can get someone else to 100%. Yeah. And us being at 70 or 80 doesn't help either, because then we go and we give our all and then it knocks us down. We'll be at 60, 50 instead. We go and we give our all again and now we're at 50, 40. And we keep giving and giving until we're at our least and we have nothing. And that's the wrong idea. We need to be able to care for ourselves. So yes, when you do have a new diagnosis, I am always encouraging for someone to go back to wherever it is in nursing that they love and they want to be, and don't take no for an answer. At the same time, I'm also saying get to know your body again, because it's going to be different. Get to know what's happening, how you're going to move, and then head back into whatever it is that you want to do. But don't ever take someone else's no as your own definitive, okay, I can't do it.
Yeah. Yeah, absolutely. I think becoming our own, figuring out where your limitation is up to you and only you.
Exactly.
You know, I think, what do you think like the biggest barrier in becoming our own advocates for things like this? I mean, I think one of them you really hit on the head is that, I mean, we're just, as a profession, we put ourselves last. We just, you know, it's so hard for us to be, you know, put ourselves first, whether that be because, you know, we're more concerned about our patients or we're more, you know, concerned about our team. You know, we don't want to let our team down. Like, I felt so much guilt for being pulled from patient assignments, you know, because I'm like, we are short-staffed, you know, like I've felt terrible about that. But like, at the same time, like, why, you know, I don't need to like break my back or, you know, herniate a disc in order to like put myself first.
Well, let's think about it this way, right? It's like, we are all about preventative care. That's what we say we are about. We are all about preventative care. So preventative care wouldn't have allowed you to feel guilty for needing to step back or take lighter duty to preserve you, because I want you to come back, right?
Yeah.
Like, that's the thought process. The thought process is, please go take care of you so that you can come back. But we don't think like that. We naturally, again, are in this facade that healthcare has to be perfect. Healthcare is not perfect. None of our institutions are perfect. The ADA was signed over 30 years ago, and it hasn't been updated since 2008. And when all these institutions love to tell me we abide by the ADA, I always say to him, so you're 30 years behind. Right? Yeah. You're literally 30 years behind. So now when we're thinking about accommodations and what this looks like for someone who identifies as being disabled and someone who does not, or someone, whatever it is, the ADA is meant for you. It's meant for you, whether you identify or don't identify. And remember, again, Mortality is fleeting. We are not superhumans. We cannot keep beating ourselves up the way that we have been, especially over the last 2.5, 3 years, where our bodies have literally taken this beating in every facet of healthcare and not just bedside. Okay, we're talking preventative care as well. And when preventative care is now being seen as a last ditch effort, that's a problem because our whole entire system is built on preventative care.
Yeah.
And we're yelling at our patients now for coming in as sick as they are. But guess what? They're told the same thing that we're told. Stay home. Don't do something. Show up and work until you can't anymore, until it's too bad. Well, then we yell at our patients for the same thing. So then we're hypocrites because we're telling our patients to come in and be seen and be cared for before it gets to that point. But yet we're doing that. We're working until the point that we can't anymore. We're going to the point where there is no return, and then our bodies break down on us, and then we can't return back to those professions that we love.
Yeah. And then we will just be replaced by,
robots, because there's no one else there to replace us because there's no one now.
Yeah. Right.
So in order for our profession to continue and grow and do all the great things that we say that we're doing and can do and will do, we have to take into account that we're human and that our humanness or our humanity is fleeting, right? It's precious. It's something that can easily be taken from us. And we know that because we are hands-on every day with patients. So if we don't look at that for ourselves, what are we really saying to the world?
Yeah, that's so true. Do you have any advice for prospective nurses that, or maybe people with disabilities that are looking at the nursing profession that, like what would you have said to yourself before going into nursing? If you could tell yourself something now.
Ooh, I think that question is like threefold. So let's start with one. Let's with the nurses first. One, that check your unchecked biases. Understand that disability does not mean inability, and it does not equal unhealthy. It's just disability. And when we see patients at their most vulnerable, we're giving them the strength to get better. They go home and they may want to come back to the profession that you have encouraged them to come back to. A lot of nurses enter the profession because they witnessed another nurse care for their grandparent. They had a nurse in their family. They've witnessed how nurses have touched and encouraged and given so much that they come back to the profession. So just check your biases, understand that disability doesn't equal disability or inability, and that everyone needs to be met where they're at, and we can always have a discussion to grow and figure out how we can always work together. A second part is, what would I tell myself when I first started was that this fight wasn't going to be easy and that I had every tool that I needed to get through it. I was already given the layout of the biggest New York City hospitals. Okay, I know them inside and out since I was 5 years old. I know every single medical device that is out there now because I literally go to all the conferences. I have to try them out for myself. I have to talk to all of these rehab doctors and figure out the new technologies. I'm constantly looking up what's going on out there. So, hearing all those doctors and nurses talk gave me all the tools that I needed to be the best that I could possibly be. And that's why I get to be on this podcast now. So there we go. You like younger me would be so proud. And then for all the nurses that are listening out there, just remember that, again, your yes is the only yes that matters. So if you believe that you can do it, you can do it. If you believe that you can't do it, you won't be able to do it. And it's always great to have sounding boards and talk to people and mentors and so forth. But it's always, what it always comes down to is your own purpose. Why do you want to do something? If you want to do something that someone else believes that you can't do or shouldn't do, ask yourself why you're doing it. And if it's for all the right reasons that you believe that are right, go for it. Don't allow for someone else's no to stop you, because your purpose is already giving you your driving force to keep going.
Yeah. That's awesome. I think that's a great place to wrap up. I I think that's a great place.
Okay.
I'm really honored to be in the workforce with you and to just like watch you and see how you're changing things and breaking ceilings. So just thank you so much for coming on today, Andrea. This was a great conversation.
Yeah, thank you, Maggie. I'm glad for having me. Thank you so much.
Yes. Where can people find you?
I am at The Seated Nurse on all the social media platforms, and you can go to my website at theseatednurse.com.
Awesome. Well, I hope to see you at NurseCon again next year. I think we said, are you going?
Yeah, in February.
Yeah. Oh, I'm going in April.
Yeah, you're doing the ship that I did originally with you. So
yes.
now I'm going to go to Dominican Republic with Nurse Week.
Gosh, yep. If there's still, I don't know if there are still tickets out, but guys, it was.
Go get it.
Go get them. All right, Andrea, thank you so much. I'll talk to you soon.
Yes, bye-bye.
That brings us to the end of the show. Thanks for tuning in to Nursing Uncharted. To learn more about today's episode, make sure to explore the show notes at americanmobile.com/nursinguncharted. And don't forget to subscribe so you never miss a guest. If you're a nurse interested in traveling, visit americanmobile.com to explore the largest database of travel nursing jobs in the industry and the amazing benefits that American Mobile has to offer. Also, a special thanks to producer Jonathan Carey, assistant producers Katie Schraubman and Sam McKay, and Aiden Dykes for the music and editing. Until next time, take care of yourself.